Hello everyone, I'm Dr. Rajiv Kovil. Welcome to the 16th edition of Diabetes News Nucleus. This is an endeavor by IJCP and it has been supported by Mankind Pharma. Our endeavor here in Diabetes News Nucleus is to get the best in the metabolic space on a monthly basis to you so that we can invoke some clinical interest, some evidence-based interest in your mind, and it can enrich your practice. That's always been the mission and vision of Diabetes News Nucleus for the last 16 months, and I hope that we have made some meaningful change in the clinical practice that you do and for the welfare of your patients. Let's have the headlines for the month, please. Thank you. So the headlines for this month is that metabolic syndrome are risk factors that we see in one individual that occurs more often than one can expect by chance. Triglyceride and glucose index, which combines fasting plasma glucose and fasting triglyceride, is a very good potential surrogate marker for insulin resistance. If you tie this to the waist height ratio, both these become excellent markers to predict metabolic syndrome. And we know that there are a lot of abnormalities in patients with metabolic syndrome that drives cardiovascular disease, cardiovascular events, and chronic kidney disease. A prospective study of an urban Chinese population with 360 men and 227 women was conducted, and it showed that this triglyceride glucose index as well as the waist to height ratio is a very strong predictor of metabolic syndrome with an odds ratio of almost 5.63, which is very, very good. Another very interesting paper, again from China, a retrospective cross-sectional study looked at patients who were taking insulin, exogenous insulin, injectable insulin, and see whether they develop any kind of antibodies to the insulin they use. So we had data for almost 1860 patients and who were using insulin, and you can imagine almost 50%, 48% of them had positive insulin antibody test. And the prevalence of this positive insulin antibody was lowest in patients who use glargine, highest in patients with human insulin, as was around 50 to 60% with other kinds of analog insulin. And these insulin antibodies obviously were not present in patients who were not using insulin. So patients who were using metformin, TZDs, DPP4 inhibitors, and other oral anti-diabetic drugs did not show any insulin antibodies. Again, another interesting study which came in the JAMA Open Network looked at COVID-related diabetes, and today we, around 1.5 years ago, we had COVID-induced diabetes, and we had this fulminant type of type 1 kind of diabetes which came around with COVID. Today we know that patients with severe COVID-19 who develop diabetes while hospitalized may have only a temporary form of diabetes. Investigators evaluated almost 594 patients who showed signs of diabetes while they were hospitalized for COVID-19, including 78 with no previous diagnosis. So almost a year after discharge, 40% of those who we said were newly diagnosed had gone down to blood sugar levels below the cutoff for diabetes. So COVID does cause some form of stress hyperglycemia, as we have known that any infection and infarction can cause this transitory condition called stress hyperglycemia, and once this physical stress is over with, the insulin and the insulin resistance that it causes can go off, and you can again remit to euglycemia or normoglycemia. Now, gestational diabetes. Last 2 months we spoke about the Cardia study and how patients with gestational diabetes in adulthood are at very high risk for cardiovascular event when they reach middle age, and that was the Cardia study. We have a recent study which looked at almost 10 patients, and they found that gestational diabetes risk was much higher after previous miscarriage. So basically the take home is that if patients have bad obstetric history, have previous miscarriages, this again comes from a Chinese study, and they find that higher risk of miscarriage and higher history of miscarriage increases the risk of gestational diabetes. So one should keep this very much in mind. And another very interesting study which came from Korea looked at NAFLD, and today we know that NAFLD is the harbinger of type 2 diabetes. It is that what do you call it, that the field person who actually converts a patient from pre-diabetes to diabetes. And if your livers are good, the chances of conversion is much lower. And the liver, along with the pancreatic fat and the kidney fat, have a lot of crosstalk in this normoglycemia to pre-diabetes to diabetes. This data, which comes from Korea, and they examined data from the National Health Insurance System of South Korea. Almost 200,000 patients were diagnosed with diabetes from 209 to 212, and they saw that NAFLD is tied to higher risk of severe hypoglycemia in patients with type 2 diabetes. And after adjusted analysis that factored body mass index, an established risk factor for severe hypoglycemia, they found that NAFLD has a 26% greater risk of hypoglycemia when compared to those without NAFLD. So NAFLD, we all know that the liver is the storehouse of glucose, and probably when the glucose stores go abnormal, you may have glycemic variability, but NAFLD linked to severe hypoglycemia, and they also showed that there was a J-shaped association between baseline fatty liver score, which is used as a surrogate for NAFLD, as the claims data lacked a histological imaging and liver biopsy finding. So if you have patients with NAFLD, obviously our whole approach is to make them lose overall weight so that the liver fat goes down, and probably do a FIB-4 scoring, and then probably risk classify them, and where we need to send them to a hepatologist, send them, or probably do a fibroscan, and probably risk stratify them again. Now let's move to the topic of the month. So for the today's topic is the significance and early identification of pre-diabetes. And let me introduce our special guest, who's also a very warm person and a very close friend, Dr. Manas Pratim Barua. He's the promoter, director and HOD in the Department of Endocrinology at the Apollo Excel Care Hospitals, Guwahati. He's a member of the Research Society of Committee, Endocrine Society of India, and former member of the Research Committee of the RSSDI. He's the former editor-in-chief of the Journal of Medical Nutrition and Nutraceutical, former associated editor of the Indian Journal of Endocrinology and Metabolism, that's the IJEM, as well as Thyroid Research and Practice. He has over 200 publications to his credit, and he has been a part of formulation of 25 consensus and clinical guidelines. Thank you so much, Manas, for being here with us.
Thanks.
Our proud privilege for having you here. Thank you so much, Manas.
Yes, it's quite a pleasure to be here, Rajiv. Thank you very much.
Thank you so much, Manas. So, Manas, today we are going to talk about pre-diabetes. So let's start for the viewers, that what are the diagnostic criteria for pre-diabetes today?
Yeah, actually, I think today's topic is quite relevant to what you discussed in as headlines. There are some objective guidelines given by both ADA as well as WHO, and we all follow that. Our fasting blood glucose, the normal cutoff is, upper cutoff is 100. So if the blood glucose is from 100 to 125, that is called impaired fasting glucose. That is one condition. Another condition is, we all know that postprandial blood glucose is 140, is the upper cutoff. So if your blood glucose, postprandial blood glucose or post glucose load blood glucose is more than 140 and less than 200, so 140 to 190, 199, then we can call it impaired glucose tolerance. So either IFG alone, that is impaired fasting glucose alone, or impaired glucose tolerance alone, or a combination of both, can be called as a pre-diabetic condition. And of course, there has been some discussion, and it's a bit controversial, of course, That's you to use another golden parameter, that is HbA1c, or glycosylated hemoglobin, as a diagnostic tool for pre-diabetes. We all know that we use that for glycemic monitoring. It's a gold standard. But
True.
some people have proposed, and even ADA also is endorsing, that you can use HbA1c as a pre-diabetes diagnostic tool. And the cutoff for that is 5.8. I mean, below 5.8%, you're normal. 5.8 to 6 point, probably 5.9 to 6.4%, you can call a person as pre-diabetic. I think the WHO criteria is 6 to 6.4. So somewhere between say 5.9 or 6 to 6.4. So 6.4 remains the upper cutoff. Between that, we can call a person a pre-diabetic. Of course, we can discuss about the limitations of HbA1c in our country, but these are the few criteria, which is objective criteria by which you can diagnose a pre-diabetic.
Now, Manas, what is the significance of this pre-diabetes? Now,
Yes, this
why
is
should
a,
we
that
diagnose
is very
pre-diabetes?
important. Diabetes is a slow disease. The whole etiopathogenesis of diabetes is pretty slow. You have a genetic predisposition. Superimposed to that, you have epigenetic changes, which is the most common, stimulatory factor for us Indians. Probably we are exposed to a lot of epigenetic change, and then finally, your lifestyle and the environment to which you live in, these are adding to the background of diabetes. So the process of having diabetes, or for that matter, pre-diabetes, would start pretty early. Maybe for Indians it would start somewhere around 20, 25, 30, and it will culminate as a frank diabetes with symptoms or complication maybe around 35 to 45 years. That is a peak for Indian or Asian population. So uh, by the time you diagnose a patient with diabetes, almost 25% would have significant changes in the end organs, or so-called microvascular complication. Moreover, we all know that cardiovascular disease etiopathogenesis and diabetes etiopathogenesis, they run parallelly. So it's something called common garden hypothesis. So if you can catch the dysglycemia, or impaired fasting glucose, or anything, pre-diabetic state pretty early, then you can intervene, and you can probably postpone those inevitables by few decades, and give postpone the onset of diabetes, postpone the onset of microvascular complication, postpone a possible fatal myocardial infarction, or stroke by few decades, and that will give, even you can increase the lifespan of a person. So there are various issues related to this. You can gain a lot by intervening early. That's why it is basically very important to diagnose our patients who are pre-diabetic, because then you are picking up a high risk group and you can actually intervene. That's my
True.
view on this. Take on this,
True.
please.
And do you think that there has been a hue and cry that probably we need to start screening by the age of 30? You know,
Yes,
you
yes, I
you
guess
you
so.
you, you think
Yeah,
that we should start
yeah.
screening
I think
at the age of?
I will give a few points in this regard. We have, you and me, we have been treating diabetics for almost 3 decades now, starting from our post graduation and all. So we have seen that the pattern is changing in India.
True.
Previously, it was almost rare to get a person of 26 years of age with diabetes.
True.
We used to expect them around 40, 40 plus. Now we know that it's happening pretty early. And Asians, for that matter, Indians as a whole, we have this fatal myocardial infarction and onset of diabetes almost a decade earlier than the Caucasians. And every decade I have seen that, this is happening pretty early. It's not rare to find 16, 17-year-old young chaps with diabetes mellitus. So the previous guideline of testing somebody if he's crossing the age of 40, I think this is pretty outdated. This is not going to serve the purpose. We must prepone it by a decade, giving respect to the whole epidemiology of diabetes, what we are seeing now. And my view is that even you can prepone it to 25 years as a compulsory screening for Indians at least. And in fact, there is another point I want to make here, Rajiv, that I've
I think something wrong with, I think, Dr. Manas's. Am I audible? I think what Dr. Manas was trying to say was that we are getting a lot of patients with much younger age groups. So when I started practice 24 years back, we would never get patients in the age group of 20s with type 2 diabetes. Anybody in their 20s was a type 1 diabetic. But today, in the last 10 to 15 years, we've seen a lot of heterogeneity occurring. You have patients who are older with type 1, you have patients who are younger with type 2. Yeah, Manas is back. Yeah, Manas,
Yeah. So
please
what I
continue.
was trying to tell you that in-depth study showed that the ratio of pre-diabetes to diabetes is 1:1. So when you say that India is the diabetes capital of the world, that means we are also the pre-diabetes capital of the world. So we must screen aggressively, we must screen early, we must intervene early. So that's very important point.
So Manas, what's the cardiovascular risk associated with pre? Is it the same as diabetes, or do you think it's slightly lower when there's dysglycemia?
Uh, Actually, what I understand is that, of course, high blood sugar, it can lead to various complications, and mostly microvascular. But macrovascular complication also not. It's not that they are not related, but we all understand that if you have pre-diabetes, they were not frank diabetes, even then you run the almost equal risk of having cardiovascular disease. So if your patient is having impaired fasting glucose or impaired glucose tolerance, if you're not aggressively screening for long-term microvascular complication, you must be very aggressive in terms of screening for or preventive action, taking preventive action for cardiovascular outcome, worse cardiovascular outcome. So that is very important. Pre-diabetics are almost equally prone to develop cardiovascular disease as type 2 diabetics. So that's a high risk group for cardiovascular disease.
Okay. Now Manas, I ask this question to everybody when we discuss diabetes and values. Now, the 126, 6.5 HbA1c, all these are retinopathy derived
Yeah.
cutoffs,
Yes.
and they are for the white populations and the Caucasians.
Yeah.
We don't really know that in
One
Indians it.
Egyptian, one Egyptian population, of course. One French
Yes.
population, one Caucasian,
Egy-
one Egyptian also.
So,
Yeah, but
do you
not
think it
not
would be
Asian.
not
Yeah.
Asian? Do you think it would be different for us? Have you ever thought about it that it could be lower? Our
Um,
our our cohort could be lower for
I
pre-diet.
think, yeah, my guess it will be probably lower. Like for BMI also, if we start having all these complications with lower, and for hypertension also, we may have a lot of other complications when it is on the lower side. I guess it could be like that. But then, unless we have a very good, well-designed epidemiological study,
True.
we would not be able to answer. Till that time, probably we'll have to accept these cutoffs,
Right. So,
international
so,
cutoffs.
so Manas, in people with pre-diabetes, which is the group that you would like? You would start lifestyle with everyone, but which would be, is there a group that you may think of pharmacotherapy? Is there a group that you will say, I'll use lifestyle for 6 months and then see? Would you divide them into groups, or everyone would start with lifestyle only
Yeah,
in
of course.
India?
Yeah, I mean, I would definitely give lifestyle advice to everyone. But then I will also look at the amongst the high risk population, there will be still a population who will be at still high risk. For example, if a person comes to me with impaired fasting glucose or impaired glucose tolerance or slightly high SB1C, and I club these people into pre-diabetic group, then if I get a history of multiple members having diabetes, multiple members having cardiovascular disease, or suppose a young lady who has dysglycemia now or pre-diabetes now had a history of PCOD, or there are certain other markers like hyperuricemia, so metabolic syndrome is just talked about. There is classical phenotype of metabolic syndrome. I have very nicely pointed out a new cutoff, the criteria of triglyceride glucose ratio. or waist hip ratio, waist height ratio, various ratios. I mean, all these high risk population, probably there I will be more aggressive. And if lifestyle modification doesn't work, it's prudent to use drugs, and we can start with metformin, and we can discuss about other drugs also, although they are not having very strong clinical evidence in terms of big epidemiological studies like diabetes prevention program. But then still, there are recent good studies showing that they can prevent diabetes because they attack the very core defect of metabolic syndrome, like even SGLT2 or even pioglitazone also has been shown to impact on that. The choice is yours, which one you want to choose, but probably metformin is time tested and we have got big studies to back it up. But in those higher risk population, amongst the population of pre-diabetic, I would try to intervene along with lifestyle modification. I like to intervene with pharmacotherapy also.
So if you are introducing lifestyle modification in one group of yours, for how long would you intensify lifestyle, and what would be the cutoff that you decide that now lifestyle is enough? I need to add on pharmacotherapy. For how long would you follow them?
Yeah, I mean, although we can start for 6 months, it's a reasonable compromise. Like 3 months is very short, and one year may be long. But then that will depend on the person. Like you cannot simply impose some pharmacotherapy for the whole life unless the patient agrees, because the dropout rate is going to be very high.
Very
And
true.
in fact, the lifestyle intervention itself is a very difficult point, because there also the dropouts are very high. So I personally feel that 6 months is minimum to see the consistency of the person. Like a person might do it for a couple of weeks, or maybe 1 month, 2 months, or maybe 3 months, but after that he may not be psychologically aligned to the exercise program, and he may just drop out of the lifestyle intervention program. So if somebody carries it for 6 months, he or she will start seeing the results. And once they get the results, their weight is reduced and their blood sugars are better, then I can declare that you have reverted to normalcy. And that's an incentive for the person. So I think 6 months for me will be a very practical, compromise in terms of duration of lifestyle intervention, and then to see the results and the person's ability to continue with the lifestyle modification program.
I completely agree with you there, Manas. Another thing, Manas, is that there are a lot of what do you call it, digital app-based initiatives today in India, bombarding patients about reversal, diabetes reversal. So patients, we have patients who are on dialysis talk about diabetes reversal. Patients who have been diabetic for 15 years on basal bolus insulin talk about diabetes reversal. So what is remission of diabetes, and who should attempt it according to you?
See, a remission of diabetes is possible. We all know that, and there are studies to show that. But then only a small percentage of population will remit. And actually, if the if your beta cells are strong enough to give you enough insulin, then only this can remit. So in a background of severe insulin resistance, like a person with morbid obesity, like BMI is 35, 40, if the person is able to reduce the body weight by significant amount, like 30% or 40%, like which is possible nowadays with bariatric surgery, that's a best example of diabetes remission, bariatric surgery, where diabetes can remit. But a small percentage of them will again start having diabetes after 7 to 10 years. That's another story. But then we should not expect a miracle. And like, we should not, our population should not be told or misguided by all these videos, all these people who are claiming that take this medicine from whichever field, allopathic, ayurvedic, homeopathic. I'm not singling out any particular branch of medical practice, but one should be very extremely cautious. And patient who has gone into insulin, requiring insulin for fairly long period, and not going into hypoglycemia with that insulin, that means the patient requires that much of insulin, then it's very difficult to imagine that patient is going to go back to normalcy without insulin. And I think we should be extremely cautious, and it is possible, but it should be left to to the experts to decide the point of reversal, not everyone. And even I know you yourself, myself, when we declare that somebody has remitted, I think we will take all precautions and we will wait patiently for a follow up, sufficient follow
True.
up of few months or even a year to declare that the patient is remitted. And even if the patient remains, he or she must continue their lifestyle modification because his risks are as good or as bad as pre-diabetic. So, what is the harm in continuing with the lifestyle modification and dietary control? And on that point, probably remission doesn't mean that you can just go out like have sweets or everything and stop your exercise and all. This is not a miracle happening here. This is
Absolutely.
science, but we must respect the science, and the remission may be followed by a recurrence in the later years. That must be
True.
remembered.
Absolutely true. Very well said, Manas.
Yeah.
Now, in patients with pre-diabetes who come to your clinic and center, are there any additional investigations other than the sugars that you would ask for? Do we have to evaluate them for people who are listening in? Should we evaluate them for
Yes,
other
yes, yes. Of
metabolic
course,
syndromes?
I'll see. I will probably look at the lipid profile. That's almost compulsory because and I'll very cautiously, carefully screen multiple times for hypertension, because hypertension, diabetes, dyslipidemia, this triad, the trinity. What I tell my juniors and what I tell myself, that if one is there, the two others are hiding, or the two are there, the third must be hiding, surely hiding somewhere. Try to find it out. So we have to screen them aggressively and with few follow-ups. So lipid profile is a must. And the rest of the things will, of course, depend on the patient's background and conditions. When the patient crosses the age of 25 or 30, I would also like to do a baseline ECG. Okay, and of course, I may not be screening them aggressively for retinopathy or nephropathy, because for onset of retinopathy and nephropathy, usually the patient has to be hyperglycemic for a substantial period. But of course, I will also do another test here, which is urine albumin creatine ratio, because microalbuminuria it can predict onset of nephropathy, and it's also a part of the metabolic syndrome which you have mentioned. In fact, microalbuminuria in a pre-diabetic patient can predict future risk of myocardial infarction or stroke, macrovascular complication. Then
True.
there is a connection. So I will also do that. Probably these are two tests. Apart from that, uric acid, which is also always accompanies metabolic syndrome, other features. So probably these three I'll do.
So we have one question from our viewer. He's saying, asking that is type 2 diabetes caused by the fat that surrounds the liver and the pancreas? So he's talking about ectopic fat in the liver,
Yes,
ectopic fat in the
very good question.
pancreas.
Yeah,
What is your
yeah,
comment on
yeah. Very good question. And type 2 diabetes, last for 35 years or so, we have understood the pathophysiology of diabetes fairly well. And initially, we always thought about insulin resistance and relative insulin deficiency. That's a beta cell centric uh, theory of the onset of diabetes mellitus. But again, there is something else in the beta cell. We all know that alpha cells. So what do alpha cells secrete? That is glucagon. And actually, a lot of people try to define diabetes as an imbalance between the glucagon and insulin. That means glucagon takes the upper hand, then insulin is not effective, adequately effective. In that case, also you may have diabetes. And when glucagon is overactive, what it does, it causes increase breakdown of liver glycogen, that leads to hepatic gluconeogenesis, and again that leads to impaired fasting glucose or increased blood glucose in the fasting state. And that is also a starting point of whole etiopathogenesis of diabetes. So having more fat in the liver is a part of metabolic syndrome. It's ectopic fat, as you have rightly mentioned. Metabolic syndrome is actually not a cosmetically looking obese may not have metabolic syndrome, but a very lean looking person may have metabolic syndrome. Why? Because that lean person may have excessive fat in the abdomen, around the liver, and the pancreas. So a simple ultrasound showing that there is excess fat in the liver, excess fat surrounding the pancreas, actually he might be a case of metabolic syndrome, even if the BMI is 24 or 25. And that is called thin fat Indian phenomenon, which is very common in our country. So we must be aware that these kind of findings can actually predict metabolic syndrome. In turn, that also predicts the onset of diabetes mellitus or pre-diabetes in the later years. Yes.
True, true. So fantastic. Manas, if you have patient with pre-diabetes and NAFLD,
Yes.
what would be your approach towards him be?
Yeah, you must understand that NAFLD is not a liver disease; it's a metabolic disease. And NAFLD, we all should know what to do with NAFLD. The first of all, NAFLD is a fat in the liver. It's a fatty liver disease, as it's called, and fat is also a stimulant for a lot of cellular mechanisms, accumulation, a lot of cytotoxins, and finally lead to liver fibrosis, and in the long run, irreversible liver damage. So, in a certain percentage of NAFLD patient will also go into NASH. Again, a certain percentage, like 10-20%, will go into develop chronic liver disease, and that could be one of the epidemics in the coming years for Indians. So that is another story. Now, to prevent the progression from NAFLD to CLD, we must be able to reduce the body weight at least by 10% by whatever means, diet control, exercise, or the drugs. And there are other drugs which are actually directly reverting liver fibrosis by reducing the cytotoxin accumulation in liver. That is, we all know about the GLP-1 receptor analogs. The recently popularized oral peptides, even injectable peptides are there. They are probably going to be the drug of choice for NAFLD. There are other drugs like SGLT2 inhibitors, and previously you also knew about the role of pioglitazone and high dose vitamin E. And of course, we have got saraglitazar, the Indian molecule, who also helps a lot in reversal of NAFLD. So there are various medications, but most important, we must understand that for our general physician friends, we must emphasize that once the patient is detected with NAFLD, the patient should be able to reduce the body weight at least by 10% in the coming month, maybe that year itself. Then probably many of them, many a huge percentage of that population can revert to normal. So that is a very simple message, and I want to give to our friends here. And what about the next another part of your question? The second part.
Was this itself in NAFLD, that what would be our treatment approach be?
Yeah.
You think pioglitazone would come higher in patients who are pre-diabetes with NAFLD?
Yes,
Unfortunately, we
because
don't have guidelines like that, but
yes, yes. Yeah, pioglitazone is a very interesting thing. Now, when I talked about weight loss, many of my colleagues might be wondering, so when we talked about weight loss and then we talk about pioglitazone the next day, so why this confusing thing? So pioglitazone is very interesting. Pioglitazone can cause weight gain, yes. That is mostly because of edema, fluid retention, but also because it can actually take out the fat cells from the omentum or in the central compartment or visceral compartment to the periphery. So the ectopic fat which was accumulating in the visceral compartment now will become eutopic. They are now going to settle in the normal, in the buttocks or in the peripheries, and those fat cells are not dangerous. It is a visceral fat which are dangerous, and that is one mechanism by which pioglitazone can help in reducing the progression of or retarding the progression of NAFLD to chronic liver disease. Moreover, pioglitazone has a receptor, PPAR gamma receptor, and acting through the receptor, it will protect the adipocytes, and in the sense that it will actually cause secretion of good adipokines, adiponectin, and reduce the secretion of bad adipokines like bisfatin. Okay, so the balance of good to bad adipocytokines will be maintained by pioglitazone. So that has been proven in the molecular science, also in various clinical studies. So that's why pioglitazone has a definite role, and it should be a part of the whole game. Like if you want to design a multi drug kind of treatment protocol for NAFLD, which probably will come very soon, maybe 5-10 years, you will see that probably it will be pioglitazone should get a place there, along with other others like GLP-1 receptor, or at least GLP-1 oblique SGLT2, or combination of both. And
Both.
probably I'd be happy to use all of them, because all of them can help, and we have seen the results in the clinical trials.
Very true, Manas.
Yeah.
So, Manas, before I close, if you would like to summarize your advice to everyone, whoever is listening to you, if you want to give them 5 bullet points about pre-diabetes,
Yeah.
what to diagnose, what to see, when to treat, and when to refer, probably.
Yeah, pre-diabetes, it gives you ample opportunity to, you know, define a high risk population. That's why once a person is pre-diabetic, usually there is a desperation. People will start saying that, doctor, I have become a diabetic. I am almost become a diabetic. I have no future. Then we should encourage them by telling that, see, this is good. You are not a diabetic,
Exactly.
but you have been detected prior to the onset of diabetes. That means I can take care of you better, and you can yourself take care. You now know that how to live your life so that you don't become a diabetic. So then I should emphasize that this is an opportunity for you to stay safe and increase your longevity. And again, a pre-diabetic in a family means that that whole family gets screened, and you get even a bigger opportunity of protecting few other people. Okay, so that is first point. And second point, again, pre-diabetic, again, it doesn't mean that it's the end of the road. There are various ways to tackle it. One, of course, is lifestyle modification if the patient is motivated. And second, of course, there are drugs, starting with metformin. Then we talked about pioglitazone, and probably
So
in the
we,
coming years, we'll have
Manas,
other drugs.
We have a question from Dr. Suresh Shukla right now.
Yeah.
He's saying, is metformin given in pre-diabetes? How much should we give and how long should we give? His question is how much and how long dose and how long should we give metformin?
Yeah, I said the first I'll take the how long. It's not easy to say how long, because if there is no side effects from metformin, you can continue, because the pre-diabetic will have a risk the entire life. So why not the entire life if you are trying to prevent diabetes in the every passing year? When the patient is getting older, the risk of having diabetes is more and more. So it's prudent to continue metformin long term, maybe the whole year. Now, coming back to the question of the dose, probably in adult population, we should use a full dose if necessary, but most of the trials is with 1000 milligram, and even the Indian trial is with 500 milligram. So if
500.
you use the trial data, 500 to 1000 milligram in Indian population is good enough to prevent, but in very obese patient, you may even use 2000 milligram, but there is not going to be any harm, but you may have a rare hypoglycemia issues, which is very rare probably, and the patient that can be modified by dietary control. So probably 1000 would be an educated, not guess. It's a probably it's a logical, conclusion, like 1000 milligram metformin, and for the whole life if you want to use it for prevention of diabetes.
And your take home to them.
Yeah, that's the second point. And the third point, we must understand that we must tell the society not to take the pre-diabetic as lightly, or not even desperate. So we should take a pragmatic view of, and we should look at the opportunity of preventing future cardiovascular disease or future onset of diabetes and so many other complications. I think these are three bullet points I want to give. Any other you can
Thank,
add, anything in your mind?
thank you so much, Manas. All the people listening in, I'm sure you all have enriched your practice from Dr. Manas's experiences. Most importantly, he said that pre-diabetes gives us a window of opportunity. It gives us a window of opportunity to intervene with lifestyle or medications to prevent progression, either to diabetes, or patients with pre-diabetes are very high risk for cardiovascular disease and NAFLD. And it's prerogative on our part, because we are getting premature complications of these metabolic issues. We should try and catch them very young. As he said that earlier, 3 decades back, we were not seeing patients in the 20s with diabetes, but today 25, 26, you have patients with type 2 diabetes with complications, and 25% of them. So it's prerogative, a medical social need on our part to make sure we are able to screen them early, we are able to catch them early, we are able to prevent the premature complications that is occurring in generations to generations. And that, if we can all come together, can be a huge thing in the whole epidemiology of diabetes and the diabetes care occurring in this country. With that, I'd like to thank Manas for being with us and giving us his expert opinions. And we will be back again next month for the 17th edition of Diabetes News Nucleus with another KOL from the country, and we will speak on another topic altogether. Now I hand it back to IJCP and the Mankind guys to take it forward. Thank you all so much. Thank you,
Thank you,
Manas. Thank you.
Rajiv, for nicely
Thank you. See
conducting
you
the
tomorrow.
show. Thank you.
Thank you so much. Thank you.
Thank you, sir, and thank you everyone for joining us today and gracing this occasion. So we'll be get back next month with the latest updates in the diabetes as a segment. So till then, enjoy your Saturday night. So
Thank
thank
you
you
so
so
much.
Thank
much,
you.
Rajiv.
Bye bye.
Bye bye. Good
Thanks.
evening. Bye bye. Bye bye.